an area we talk about a lot these days because it's such a critical issue for hospitals. It has to do with surgery. Right, surgery is a big deal for hospitals for a bunch of different reasons. Surgery, for a lot of hospitals, accounts up to about 70% of the revenue that they make and about 60% of the margin. So it's a big part of the financial success of hospitals if they do it well. But also, it's interesting, the patients we see now coming in for surgery, a lot of them have gotten older, they've gotten more complex, they have more problems from a medical standpoint, and the surgeries that we're performing on them are actually much more complicated as well. So when it comes to surgery, again, you want to have great surgeons doing obviously really, really good procedures on each individual patient. But really, if you want to impact quality broadly, you need a system, a great system that can take every single patient that's coming in for surgery, really understand everything that's going on with them from a physiologic standpoint. Understand maybe there's some of their conditions, their diabetes, their heart condition, how well their lungs are functioning. And so a lot of the work we do is to build a system of evaluation, which is top notch, absolutely cutting edge.
Hello and welcome to the HealthBeats podcast. My name is Steve Gardner, Managing Director of leading international healthcare magazine, Healthcare World. We are here today, supported by Abu Dhabi Global Healthcare Week, for another edition of one of the best podcasts I hope you'll find anywhere on healthcare internationally. If you haven't already subscribed, why on earth not? You'll find us on Apple Podcasts, Spotify, and all the other places you can find podcasts. Preamble over, it's time to introduce today's guest, who is Dr. Rick May out of Denver, Colorado, a man who has spent the last 17 years of his life troubleshooting problems and issues in hospitals all over the US and all over the world. But it didn't start there, did it, Rick? You started off, and I loved this when I was looking at your bio, as a computer programmer at NASA. So how does a NASA computer programmer become an orthopaedic surgeon and then a man who troubleshoots global hospitals?
Well, Steve, first of all, thank you for having me on today, and I agree. Your podcast is amazing. Everyone should subscribe, definitely. So that's the first pitch. As far as my journey, honestly, I got very, very lucky. I started off, I think, like a lot of young men my age, I was fascinated by computers growing up, and I taught myself how to program computers starting about age 13. And also growing up, I watched NASA all the time. I watched what was happening with the astronauts with rapt attention, and always sort of dreamed about that potential. And along the way, just sort of coincidentally, I was doing research here in Colorado, looking at specifically how things like microgravity affect how people breathe and how it affects human physiology. And the place I was working, NASA reached out to us and said to the professor I was working with, they said, "Hey, do you know anybody that knows physiology and also knows how to program computers?" And he looked at me and said, "Rick, do you want to go work at NASA?" And I said, "Absolutely." So it was.
How could anybody say no to that?
I was going to say, when NASA calls, you basically only can say yes. That's the only correct answer. So that's how I really got into it and got to work down at NASA for about 3 years. And it was fascinating, really, really interesting time for me. And my primary work was doing a lot of different analytics, but my primary job actually for a long time was I was developing essentially artificial intelligence systems to guide exercise programs for astronauts on the International Space Station.
And this was all the way back in the 80s, right?
Yeah, this is back 80s, early 90s when I first started there, yeah.
So artificial intelligence in the 1980s, how does that relate to what we see with ChatGPT today?
Well, back in the 80s, AI was like on an abacus. It's a much different AI than you see today, certainly. So it was not quite as sophisticated. It was frankly really, I think, more just than anything else. It was sort of sophisticated rules engines, obviously much more evolved than it is today. But it was kind of the framework that was used, I think, to build what we see today. So it was a fascinating time back then. Again, it was a very complex problem on how to manage astronauts and exercise and physiology in that environment. So it was really a fascinating exercise.
Sounds amazing. Sounds absolutely amazing. So how did you go from that to where you are today at Berkeley Research Group?
Well, it's interesting. I along the way, I was working at NASA. I actually applied to medical school along the way, and very interesting week. Back in about 1991, I got a call basically from the director of the Life Sciences Division in NASA where I was working, an astronaut there who said, "Hey, listen, Rick, we like your work. We'd like you to stay here permanently." And I said, "That'd be great. I'm on. I'm in. Count me in." And then 3 days later, I actually got a call that I'd received my acceptance to medical school. And when I talked with the head of NASA for life sciences, he said, no, go do medical school first. If you'd like to come back, please come join us. So I went to medical school, got into orthopedic surgery because I like to fix stuff, which is orthopedics is basically just, kind of like working in your garage, sort of a glorified mechanic, essentially working with very expensive power tools. Which I loved. It was great. Orthopedics is a very great specialty because every day you get to go to work and fix people, right? You make them get better, which is fantastic. But it's seriously for me, I'll tell you, Steve, I along the way, I always did my work kind of one patient at a time, but I started reading more and hearing more about the idea about really broad-based quality improvement for systems. And I began to wonder, is there a way to take kind of that work I do one patient at a time and be able to expand it to say, okay, let's work on system improvements, and now we can help dozens or hundreds or even thousands of patients at a time. And I had the opportunity to kind of move and try some of that work, and I found it just incredibly interesting, challenging, fun. And so over the next 10 years or so, I did less and less orthopedic surgery and more consulting work in this improvement area, and now I do it full time.
So that whole idea of being able to take hundreds of patients and improve their quality of care in one go. Explain to us, give us some examples of the kind of things that you've done that have had that kind of that impact on patients.
Well, it's interesting. I know we talk about it a lot these days because it's such a critical issue for hospitals. It has to do with surgery. Right, surgery is a big deal for hospitals for a bunch of different reasons. Surgery, for a lot of hospitals, accounts up to about 70% of the revenue that they make and about 60% of the margin. So it's a big part of the financial success of hospitals if they do it well. But also, it's interesting, the patients we see now coming in for surgery, a lot of them have gotten older, they've gotten more complex, they have more problems from a medical standpoint, and the surgeries that we're performing on them are actually much more complicated as well. So when it comes to surgery, again, you want to have great surgeons doing obviously really, really good procedures on each individual patient. But really, if you want to impact quality broadly, you need a great system that can take every single patient that's coming in for surgery, really understand everything that's going on with them from a physiologic standpoint. Understand maybe there's some of their conditions, their diabetes, their heart condition, how well their lungs are functioning. And so a lot of the work we do is to build a system of evaluation, which is top notch, absolutely cutting edge, that really takes all the current science that's out there and says, okay, how do we need to look at these patients to understand really their unique situation? And then also, how do you optimize each one individually, specifically for the surgery that they're going to have? And that's a great example to say you could have a big hospital system that may have 5,000 or 10,000 patients a year coming in for surgery, put them all through this much more sophisticated evaluation optimization system, and the results are incredible. I mean, the complication rates for those patients come down, their time in the hospital goes down, the outcomes of the surgeries are better. It's remarkable. So a system change like that affects, again, all the thousands of patients that go through it.
So, I mean, is it any different to running a business from that point of view? It's really about having the right systems in place, the right checks and balances, the right understanding and the right information.
Exactly. It's very similar, right? Like any business, you want to have good employees, right? You need to have good surgeons, good nurses, good anesthesiologists, good people working for you, well-trained, diligent, care about what they do. But you're right. In the absence of a good system, it just all doesn't work. In fact, we talk with hospitals a lot about this. In surgery, you can take a great surgeon and put them in a mediocre system, and they look pretty average, frankly, pretty fair. Conversely, you can take an okay surgeon, a pretty good surgeon, put them in a great system, and they will have fantastic results. So it's really that system is so critically important, and surgery is one example. Within healthcare, within hospitals, there are so many examples like that. It's about how do you build those really robust systems that are going to consistently deliver that great, perfect care for every single patient every single time.
I guess being in Denver, the example to use would it be? It's a bit like being a quarterback, isn't it? If you've got a good quarterback in a poor team with poor teammates around him and a bad system, he's not going to succeed. He's not going to win games. Whereas you get those quarterbacks that are average players, but you put them in a good team and they work better. Is that a good analogy?
That is a good analogy, but I have to say I'm impressed that you went to the American football example as opposed to the what we would call the soccer example here. But no, you're exactly right. You need to have a star player only looks like a star player when they've got a really good set of other players around them. That's very true.
I think it's always important to contextualize one of these interviews, Rick. So yeah, from that point of view, I thought it was a reasonably good idea. I think again, I mean, to stretch that analogy still further, how important is it to have the buy-in of the players, or in this case, the staff, to the kind of systems that you're trying to implement?
Well, as you might imagine, it's critical. I mean, without the sort of the acceptance, the willingness on the part of the hospitals, the people in the hospitals, to really accept what we're doing, to accept these new ideas, to be willing to evolve their thinking, their way of doing things, nothing's going to work, clearly, right? They have to be on board. Now, that can be a challenge, though, honestly. So many hospitals, I think, have been through these cycles of consultants where they come in, they're like, okay, we're gonna fix stuff, we're gonna change stuff. And a lot of times, some of those consultants have come in really to say, we're going to basically work on saving a buck here or there, right? Trying to, help things financially, which a lot of times is not very well received by the staff of the hospital. They see that as, hey, they're going to cut resources, things like that. A lot of the work that we do really has to do when we go into hospitals is to work with the staff, the physicians, the nurses, the techs, the leadership there, to help them understand sort of really two things. One is that we really care what they care about. That we're here because this is about improving care for the patients. It's not about trying to save some dollars. It's really about, really helping them do a better job of what they care about most, which is deliver great care, great quality for their patients. So that's kind of number one, is make sure you really got that they need to understand why you're there and very sincerely why you're there to help them. The second piece really is to be, I think, frankly, very experienced at what we do. The folks in hospitals right now, they have so much on their plate. There's so many things they're trying to manage. You can't come in and be sort of meandering around. You got to be very definitive and say, to fix surgery, we're going to do this, this, and this. When it comes to sepsis, this is the shortest path between where you are today and where you need to be. So it's one, making sure the folks know there that we're there because the same reasons they're there, but also be good enough that you can make the changes quickly and efficiently because they need that in this day and age.
I mean, there is the thing, isn't there? I mean, clinicians, particularly surgeons, are very highly educated. They're very high functioning individuals. Sometimes we hear stories about that level of individual being resistant to change. Has that ever been a problem from your point of view, just having senior people within these hospital organisations who are just saying, look, no, the way we do it is the best way of doing it and we don't really want to change?
Well, it's interesting, and we have come to accept this. In any hospital system we go into, and this is really true among surgeons, among other physicians, among nurses, among the staff, our experience has been that 20% of those folks in any of those groups, let's just say surgeons, 20% of the surgeons will never accept the change. Either because they're just burned out, they're emotionally not ready to sort of take on that conversation, or they do feel like, I've been doing this for a long time, I'm great at what I do, I'm not going to change. And that's okay. We accept the fact that 20% are just not going to be on board, and we'll work with the 80% that are excited. We're going to take that army of the willing and make those changes. And I think that's one of the key pieces, is to recognize that you can't always 100% make those movements happen, but work with the folks that are willing to. The second piece has to do with, again, it's important to think about how quality improvement works in hospitals. If, for example, a consultant comes in and talks to a hospital about their revenue cycle, right? How they bill and collect for things. If they come in and make really, give them dumb advice, they give the hospital sort of bad ideas, right? And the hospital does those things, well, maybe that's what messes up their billing and maybe they lose some money. If you go to a surgeon, let's just say a heart surgeon, for example, and you say, hey, listen, Dr. Jones, I want you to change what you're doing, what you've been doing for the last 20 years, right? Because there's a better way to do this. As you might imagine, that role, that surgeon, they are so focused on what they do and try to get great outcomes. Literally, if they mess up, if you give them bad advice, it's not like they lose some money. They literally can kill people. So we expect the fact there's going to be that skepticism there. So we talk a lot with those folks at that level to say, what do you do today? Let me show you how what you're doing today is affecting your results, sometimes in negative ways. Let's talk about really the most current research and also what your peers around the country have evolved to. What's the new way of doing things? And so by respecting what they've done before, acknowledging that, but also showing the current impacts of not evolving and sort of give them a clear path. Again, 80% of the time we can get those surgeons, those doctors, anesthesiologists, nurses to make that jump.
What do you then do with the other 20%? I mean, I'm shocked it's that high, for one thing. I mean, that's a pretty hefty number. But at the end of the day, if there is a system there and there's a system in place, is it a question of winning that 20% over time? Are there a certain number of those individuals you're never going to win over? Do you have to ultimately turn around to these people and say, no, this is the way that things are going to be done, therefore you're going to have to live with it?
Yeah, Steve, it's more that last thing you mentioned. The 20% tend to be, in my experience, unmovable. Maybe a few over time will come over, but for the most part, that 20% stays the 20%. They're like, nope, I'm not going to change. And then it's a question for the system, right? The system may come back and say, listen, if you're going to work in our hospital, we are going to evolve. We are going to move forward. This is what you're going to have to do if you want to stay here. And sometimes those providers will just, either leave the system voluntarily, or they'll be forced out. They have to leave, because a good hospital at the end of the day, even if some of the folks are like, I'm not really sure about this, a really good hospital recognizes they have to continue to evolve. They have to move to these better systems. And if there's folks that are just not on board with that, sometimes it's better to part ways with those folks than try and work around them and accept the fact that you're going to, frankly, provide sort of substandard care for that 20% of patients taken care of by those folks, rather than simply saying, we have a responsibility to take care of all the patients, 100% of the patients, the best way we can. So maybe it's time that we part ways.
I mean, I guess at the end of the day, people are people and work is work. It's a management issue,
Yep.
just like it would be in any other business. So
Right.
I guess from that point of view, that's just kind of the way it is. I mean,
Yeah.
surgery is one element, and obviously you work across all sorts of different areas of hospitals and health systems.
Yeah.
What are the common performance issues that you see on a regular basis? What are the most common problems? If you're brought into hospitals having performance issues, what are the most likely things that you're going to see?
Well, that's a great question. If you think about all the things that sort of could go wrong with coming into a hospital, right? There's a lot of bad things that could happen. In the simplest possible terms, we look at the stuff that could go wrong and make those things happen a lot less, or hopefully not at all, and also implement the systems I was talking about before to really provide the best care. So, for example, obviously mortality, so deaths in the hospital is a bad thing. It's interesting. There's a lot of things that you can do to understand kind of what drives that. Is it a really clinical care issue? Patients coming in with heart failure, for example, are the doctors and nurses taking care of that patient? Do they really not know what's going on with that patient? Are they not doing great care? That's pretty uncommon, actually. What tends to happen more is, what is the system of care around that patient? What's happening as that patient leaves the hospital? What can you do to help their heart failure, even though they're not physically in the hospital? So you have to look kind of beyond the walls that way. But there's some really common problems I think just have to do with what happens in human beings. So there's patients that come in with a lot of chronic medical issues that go from sort of stable and okay with their normal lives to getting worse. So they can have a heart condition that suddenly gets worse and they have to be admitted. So heart issues are very big. Cardiac, pulmonary issues, especially among smokers, are a big problem as well. Even things like infections. Infections are a really interesting problem these days, because infections are getting, in many ways, much more difficult to take care of. So many of the germs, the viruses that cause infections now, are becoming resistant to some of the antivirals, the antibiotics that we use. So that becomes an increasing problem. A lot of hospitals are seeing that. Sepsis in U.S. hospitals, which is basically when one of those infections sort of takes over your whole body. Sepsis is a huge problem in U.S. hospitals. It's been going up pretty much consistently for the last 10 or 15 years. And again, harder and harder to treat in those very, very sick patients. So infections, sepsis is big on the list. Again, surgery in general, there's a lot of complications still happening around surgery patients, primarily because they come in and have a great surgery. Technically, it's a good surgery, but then afterwards they get a lot of problems. Maybe they get pneumonia, or they get delirium, or they had a stroke, things like that. So it's a series of big stuff. The complications, the infections, and things like surgical care. Those are some of the biggest ones we see today.
And I guess there's a big data issue here, isn't there? In terms of, you've got to have good benchmarking, good understanding of what good looks like in terms of the quality of outcomes and the data that you're capturing on those outcomes, in order to understand where the system is going awry. How much of a role does data play in your day-to-day life?
Oh, it's everywhere, and that's actually one of the things for me. Again, just because I had this background in doing data analytics, I never thought that my NASA data stuff would actually be applicable to what I do in medicine, but I use it pretty much every day. But Steve, I'll tell you, it's a very interesting place we find ourselves today in the U.S., but also I think around the world. I think people will be very surprised to learn how little data, really good, reliable data, that most people, most providers, physicians, nurses, techs, most people that work in hospitals today taking care of patients, how little really, really great data they have to work with. It's very surprising. The data sources we use tend to be kind of fragmented. Sometimes we get it on certain patients, other times we don't. Sometimes it's very limited, meaning I see a little tiny part of a patient's issues or problems, but not the whole thing. One big problem we see today, frankly, is hospitals get all this data thrown at them, but they don't know how to take the data and turn that data into something meaningful, right? An insight. Oh, wow, we're having a problem with infections, and here's why. So take the data, the numbers, and make it into an understanding. And then if they even can get that insight, a lot of times they struggle to take that insight, that understanding. Wow, we do have a problem with infections, and actually make the change, how to implement it. So data is this ongoing issue. There's not enough of it. It's not the right type of it. It's not being used correctly. It's not being analyzed right. It's not ending up in the hands, for the most part, of the people that actually could do something with it. And even those people that could do something with it can see it and understand it. A lot of times they don't have the time and the resources to actually make a change.
So how would you go about changing that? How would you go about, if you were advising a hospital or a facility, how would you go about giving them the tools, the advice, the knowledge to be able to improve that data and give them something actionable that they could understand where their care was lacking or where the problems might be within the treatment that they're offering?
Well, again, that's such a critical issue. You think about it, we can come in and talk about, hey, let's talk about what's a big issue. So central line infections. A central line is basically, if you ever had an IV in your arm, those little plastic tubes. Well, imagine kind of a much bigger version of that. There are certain medications, for example, that if you try and put them into those little IVs in your arm, the veins in your arm don't take it very well. So you need a bigger pipe, essentially. So a central line is like essentially a big IV that goes in sometimes in your neck, sometimes in your top of your chest. Which is a great way to get a lot of fluid in. The downside about having a big central line is that if it does get infected for some reason, it goes right into where your heart is and it'll kill you really fast. So central line infections are a big problem. To manage central lines and avoid those infections, you need to have specific data, not just about how many infections you have, but you need to know, for example, how many lines are being put in every day. Why are the lines being used? How many days per line? Obviously, the more lines you have, the more time they spend in people, the more chance they can get infected. And even basic stuff like how are those lines being cleaned and changed every day. So I use that as an example to say, for a hospital to really get their arms around that, they need to start looking and say, okay, what information do I have? Okay, starting off with, I have the number of infections, but recognizing to really manage the problem, I need to now start collecting data deeper. I need to track the number of lines. I need to track the days per line. I need to track basically where the lines are placed. I need to track on a daily basis how those lines are being maintained. So we talk a lot about identify the problem we're trying to solve, central line infections. Identify the factors, the processes that go into essentially, that tell you that sort of end result. And then help work with hospitals to find the data sources they need to pull all that data together and put it in front of the people that understand it. That's a lot of the process. Define the problem, define the specific data needs that you need to drill down into, and find out a delivery system that can put it in the hands of the people that need it.
It sort of sounds like you've gone from NASA to orthopaedic surgery to being Sherlock Holmes. You're now in a situation where you're doing it. You're searching the data, you're looking at the available information, and you're trying to search out, not in this case who committed the crime, but where is finding the problem, finding the issue. It sounds to me like at least half your time is spent working out where the problem is and what's caused it. Is that right?
Well, Steve, you're being very kind, I think. And if you know orthopedic surgeons have a reputation. There's a lot of different nicknames for orthopedic surgeons. Talk a lot about orthopedic surgeons tend to be the surgeons that are basically strong as an ox and half as smart. So that's kind of the characterization of my type of surgeon. So
I think it's the orthopedic surgeons are to medicine what drummers are to rock bands.
That's a great analogy. There you go. I would be considered sort of the Ringo of my specialty, I guess, but the Ringo among surgeons. So we pound a lot and make a lot of noise, but if you ask us to do something creative, like make a song, that's not our forte at all. So, but I think again, one of the key pieces with all of this is really how do you sort of mobilize the pieces? How do you take the understanding of the problem? And whether that's a Sherlock Holmes approach or not it sort of depends on the situation. Now, maybe if I take your analogy a little farther, Steve, I will say this. I'm no Sherlock Holmes, but we do have to solve some mysteries sometimes about what happens and what caused it. The biggest advantage I have, though, is that for most hospitals, the things that go wrong are the same things over and over again in almost every hospital. So it's kind of like being Sherlock Holmes, but solving the same murder everywhere you go, right? It's always the butler, or it's always it's always probably the surgeon in our world. It's always going to be the surgeon committing the murders, killing people. But you know what I mean. But anyway, so it's that's the advantage. I get to do the same thing over and over again. So the problems that affect hospitals in my home in Denver, Colorado, are basically the same that affect hospitals in New York City, that are basically the same that affect hospitals in London or Abu Dhabi or in Bangkok. It's very, very similar because the core folks we work with, the human beings involved, are similar. The kind of problems they have, the pathologies they have, tend to be the same, and that's why the treatments tend to go off the rails in the same way.
I think one of my favourite Sherlock Holmes quote was the one about, once you've eliminated all of the probable solutions, then the improbable solution must be the one that you pick up. Is there a time in your career, is there a point in your career or a story you can tell us about a problem like that, where you're really proud of something that when you delve down deep into the data, that you discovered something really fascinating and really interesting and really unusual?
Oh, that's actually a great question. That's a fantastic one. Actually, this is sort of an interesting one. I think it's very similar to that. Is that so? There's a problem you see. It's very common in hospitals, and it's a bad problem that they call C. difficile. And C. difficile is it's basically a bacteria. It's a bug, right? It's a germ. And what happens is in the hospital, when people get antibiotics, the antibiotics tend to kill off a lot of other germs that, interestingly enough, compete with C. difficile and stop it from growing. And so by giving certain antibiotics, you may kill off a lot of bacteria, for example, but the C. difficile is like, I don't care. I'm immune to that. And so now it grows crazy and becomes a huge problem. And it can actually kill people. It's a big deal, right? But what's interesting is you say, oh, well, wow, I wonder if what the problem is here is basically how we're managing the antibiotics. We have to look at that, and we spend a lot of time. So the obvious sort of killer, right, the one you go to, is the use of the antibiotics. That's going to be the main way to go after. That's the probable cause, as you said. Well, as it turns out, though, when you really dig into it, you go through the different possibilities, and you're like, wow, the antibiotics are being used correctly, and it's not. And you work through it and say, it turns out the antibiotics actually aren't the main cause here. And it turns out when you do look at other things, you say, wow, well, if it's not the probable option, the antibiotics are being used incorrectly. Again, like I say, what's left? What's the improbable cause? And in the case of C. difficile, a lot of time has to do with how that particular bacteria is being tracked, or what they call cultured for. So in other words, how do you identify the bacteria when it exists and then know what to do with it, essentially? So the obvious solution is, the antibiotics are the killer. The antibiotics are the bad thing here. It turns out in a lot of situations that's not the case. It's actually this other very small improbable thing, which is, wow, the way I do my labs to look for C. difficile, that's where the culprit lies, is in that piece right there. Like you said, when you eliminate the probable, what's left is the answer, despite how improbable that might be.
And I imagine when you've got a problem like that takes some time and some effort and some work and some real thinking to solve, that's probably the most rewarding part of your job, is it?
Oh, it is. It is. It's just that when we have people that come like apply to our teams to join us, I always tell them the same thing. If you like doing the same thing every day, this is not the job for you. This job alternatingly in one day, it can be inspiring, it can be exciting, it can be incredibly frustrating, incredibly challenging. But the best thing it's about fixing, it's about solving problems, it's about understanding, here's the problem I'm trying to solve, here's the mystery in front of me. How am I going to solve it? Is it something I've seen before? I think I know how to solve this murder because I've done this kind of thing before. But a lot of times it's something brand new for us. And that's what makes it so interesting, so exciting. It's every day is different. And even after doing this for 17 years, I still go places and hospitals will come and say, hey, we got this one problem. What do you think? And I'm like, initially, wow, I got to tell you, I've worked in hundreds of thousands of hospitals now, I think, in the United States. I have never seen that problem before. And that makes my day. That's like, wow, here's a brand new mystery to work on. And the upside is, honestly, Steve, is we're pretty good at what we do. I mean, we can solve almost all of them. We almost always find the solution, find the culprit, and find a way to fix it.
So did you enjoy doing puzzles when you were a kid?
Yes, very much so, very much so. And And the caveat too is that's probably why I ended up there was orthopedic surgery. Orthopedics is very much about puzzles, right? I mean, think about you're driving down the street on your motorcycle. I'm not sure if you're a motorcycle guy, but and you're driving a little too fast, you're listening to your headphones, you're not paying attention, whatever else. Anyway, for some reason you end up at 70 miles an hour, kind of rolling, head over heels down the highway, and you break a bunch of different things. Well, you then come in to see someone like me, and maybe your femur bone, which should be one solid piece, is now in like 8 different pieces. And so part of the job of the orthopedic surgeon is to put all those pieces back together. And for example, if you're missing pieces, what sometimes happens, how are you going to fill in the gaps? So a lot of it is puzzle solving on human beings, which is an interesting metaphor, but it's true. A lot of the work is like that. So.
I want to take we talked there about the unusual example. Let's take a more obvious culprit, a more obvious example here, and delve into that. You mentioned sepsis.
Yes.
Earlier on in the conversation as being a common problem in US hospitals. It's also, as I understand it, a common problem in Middle Eastern hospitals. Our colleague Julie Coop, who we both know, and deserves a shout out, I think, during the course of this conversation for introducing us, if nothing else, was telling me a few days back that sepsis is sometimes an issue in the Middle East hospitals she works in. If that's a common problem, instead of let's flip this around. We talked about identifying the problem. Now let's talk about the solution. So if you are presented with a hospital that has an issue with sepsis, what's your process? How do you go about solving that problem?
Well, sepsis, I'm glad you brought this up because, again, sepsis is one of those really, really challenging issues. And where a lot of things, if you look at things like heart failure deaths or even cancer deaths around the world, in a lot of ways, those have been moving down. I mean, there's been a lot of work to kind of push, a lot of those different conditions to get more control, to diagnose them earlier, to basically, get your arms around them and make them better. We haven't eliminated them yet, but they're certainly doing better. Sepsis is not that way at all. Sepsis is going the wrong way. Sepsis is going the wrong way here in the United States. It's going the wrong way around the world. And the real reasons for that are interesting. There's a lot of mystery behind that as well. It's probably something to do with, again, antibiotics being less effective. In some settings, it's because patients don't have access quickly enough. So they maybe develop a pneumonia or even like a cut on their hand, for example, which should be relatively minor if treated early, but they don't get the care they need quickly enough. And so that makes it, allows that bacteria to grow and spreads your entire body. It is important to remember, Steve, if you go back 100 years ago before antibiotics, people would die all the time from like cut on an arm or a simple pneumonia or, even like urinary tract infections, very, very simple infections, which today are, relatively easy to treat with antibiotics. They kill people all the time because people would just get sicker and sicker, become septic, and it would just ultimately kill them. So sepsis now is, again, the fact that it's getting worse, we're seeing more of it, it's killing more people, even in hospitals, it's a significant problem. So back to your original question about how do you get your arms around it? Well, it's interesting. It's important to recognize sepsis is not the same as sepsis is not the same as sepsis, meaning sepsis for a patient who is a 25-year-old coming in from outside the hospital who has, they're coughing and sort of sputtering because they have a pneumonia. That type of a sepsis case is very different than, for example, a patient who's had a big surgery on their bowels or in their intestines, whatever else, and is a couple of days out from surgery and now suddenly starts to look very tired and very weak, and their fever starting to go up. So in what they call, hospital-acquired sepsis, or sepsis again that's in a different age group. You can have sepsis even like in newborn kids. You can have sepsis in mothers who have just delivered babies. You can have sepsis in 80 years olds. So a lot of the initial work is to figure out, okay, where are we seeing the sepsis? First of all, because it's not the same. And then also find out, okay, what are the drivers? Is there some reason why, if we're, for example, a hospital that delivers a lot of babies, we're seeing more sepsis in those moms after they've delivered? Okay, let's start drilling in. What are we doing? It's part of that birth process. What are we doing or not doing that might be encouraging that? So we had to drill down on that piece. The final thing I mentioned about sepsis, a lot has to do with, one, figuring out kind of what's causing it, but then also having great systems in place that when you start to see sepsis or even suspect it, that you can, basically on the sort of the snap of a fingers, move immediately with lots and lots of people and resources to that patient immediately and to do a whole bunch of stuff. They call them the bundle, basically, of all these important steps to do really, really rapidly, because sepsis kills people a lot and it kills them really fast a lot of the time. So you need to recognize that it's sepsis. You need to mobilize all the resources. You got to do the right stuff in the right order very, very quickly. And that combination is what starts to bring sepsis down. but it by no means fixes it. I mean, we've never found a hospital we can completely eliminate sepsis. I don't think anyone ever has. But by that process of understanding where it comes from, where the care deficits might be encouraging sepsis, allowing sepsis, and then having a system to rapidly respond to it, that's the key to getting your arms around sepsis.
And what are you talked about the kind of types of systems, the types of processes that can alleviate different kinds of sepsis. Can you give us any examples of kind of specific ways in which you've tackled different kinds of sepsis in the past?
Yeah. So again, by thinking about sepsis bundles, and the idea about bundles is very interesting. Is that the idea is there's been a lot of research to say, okay, if you suspect somebody's getting septic, that infection is spreading out to their whole body, what do you have to do to basically address it as fast as possible? So some things are pretty straightforward. You want to take their blood and you want to look in the blood and see if you can figure out what the bacteria is, what the cause of the sepsis. It's what they call the cultures. So you want to do cultures fast. That's one of the bundle elements. Also, you want to actually start antibiotics very fast. You want to get those antibiotics on board. Usually what they call a broad spectrum antibiotic, because you may not know for sure what's causing the sepsis. You want to use something that's a big hitter. Sometimes in medicine we have what's called a gorillacillin. A gorillacillin is, think penicillin is like a little thing. A gorillacillin is a big monster antibiotic that kills a lot of stuff, right? So you get those big gorillacillins on board fast, those broad spectrum antibiotics. Also, interesting enough, you also want to check the patient's blood to see how acidic the blood is. This is getting a little technical, but basically our blood is very, very carefully maintained in our bodies a certain amount of how acidic it is. They call the pH. And when people start to get sicker and sicker with sepsis, their blood basically becomes more and more and more acidic. And as you might imagine, having potentially more acid in your blood might be bad for you. It's absolutely bad for you. It hurts all of your organs and helps, it basically sort of hastens your death. So how do you get that, what they call a lactate, which checks acid? How do you rapidly get a lactate? And then one of the big things too is that patients with sepsis have been shown you got to get a lot of fluid into them. I'm oversimplifying, but it's kind of like you want to wash out those germs. You want to get a big IV in, like one of those central lines, and push a bunch of fluid with them. So cultures, broad spectrum antibiotics, lactate to look for acid, and then also lots of fluids. Well, to do that effectively, one, you have to have a system that's, when somebody starts to show signs of sepsis, anybody in the hospital can raise their hand and say, hey, I think this patient may be having sepsis. So number one, everybody's empowered to identify and raise their hand and say, I think we have a problem here. Number two is that when that hand gets raised, you can literally call over the announcement system or the pager system in the hospital to say, we have a sepsis alert, and a whole bunch of people stop what they're doing and go immediately to that patient and say, okay, let's evaluate them. And then that team has the ability, they call it a sepsis rapid response team, to do all those things, to draw those bloods, to get those fluids going. And that can be, in an intensive care unit, that can be on a regular hospital floor, that can be in the emergency room, that can be in the waiting room, potentially. If somebody recognizes sepsis, raise their hands, calls that alert, that rapid response team is going to show up and they're going to do all those things they need to do fast. And that's the key. And surprisingly, a lot of hospitals, they do some of those parts, but don't have the whole system together. So they just don't have the package they need to really manage sepsis well.
And this, I guess, is where you and your BRG team come in right. terms of going into those facilities, setting up that sepsis response team, setting up that process around what happens when that person goes, oh, whoa, we've got somebody who might have sepsis here. That's your job. That's your role.
Yeah, exactly. And as you mentioned before, I'm going to tie it back to the other point about the data. The other part we'll do a lot of is to say, okay, we want to build that team, build that alert system, but also let's talk about what data do we need to be tracking to see if we're actually doing a good job of this. I mean, how frequently are those sepsis alerts being called? How much time does it take from the time somebody raises their hand and has, I'm concerned about this patient for sepsis, and the sepsis response team shows up? How fast to get those labs done? How accurate are you in identifying the bacteria that are causing those problems? So that's another critical component. You have to have the systems in place, but back to your original point, you got to have that data to really understand, is what we're doing actually working or not?
And also, I guess what you also need to understand is what is the kind of baseline level. Sepsis, I'm going to come back to this in a moment. I think it sounds like it's becoming a bigger and more insidious problem with the advance of AMR. But at the end of the day, there are kind of levels of sepsis cases in most facilities.
Right.
The point is you need to have the data there to understand when there is a spike and then understand why that spike is happening.
Right, exactly. And what's interesting is if you track kind of any any, I guess, bad thing in a hospital, probably some good things too, but certainly bad things. As you might imagine, month to month, some month you'll have a few more infections, and some month you'll have a little bit less infections, and some months you'll have more readmissions, and some others, and maybe some deaths, and they'll go up and down. And we talk about the data looking like a mountain range, right? It's kind of up and down, and up and down, up and down. What's interesting is the question is, okay, suppose I'm down a little bit here, and then I have a little bit of a spike that looks a little higher than the rest of the spikes. Is that significant? Is that just maybe a little worse, but it's not significant? And what's interesting is it's a matter of saying, yeah, I'm going to collect this data, but it's also an understanding about how you actually analyze data, how you manipulate data. So in the case of like the mountain ranges, you basically, it's called control limits. You basically follow the data and you can mathematically say, hey, I'm going to draw this line right here. And what that says is when a spike goes over this line, over this level in this particular month, that's a big red flag. That's not just a normal variation like we see it, every month, month to month, but this is something that's out of line. This is out of whack. So one, I need to identify it. And then I have a process where the people that can start investigating know right away, wow, over the last 30 days, we've had a big spike, an abnormally high spike, a significant spike in our sepsis, cases, our sepsis deaths. That's going to trigger a much, more robust process. Find out, okay, what are we not doing? Wow, we're going to dig into it. We're going to find that our sepsis alerts are not happening fast enough, or our rapid response team is not getting to the bedside fast enough. So you have to say, let's follow the data, understand when to identify a problem, but then how are you going to mobilize resources to fix that problem as fast as possible?
I guess you mentioned the R word that I think most hospitals are terrified of. Sepsis is one way of, issue with multiple causes that can indicate problems within a hospital, within a facility. But the R word I'm referring to is, of course, readmissions. Because readmissions, how much are levels of readmission indicators that there is something wrong with an individual hospital or facility?
Oh, that is a great question, Steve. It would probably be easy to say, oh, yeah, if you see a lot of readmissions, that's because the hospital's doing a bad job. That is as a vast oversimplification, because if you think about what a readmission is, right? Readmission doesn't sort of start when the patient's outside the hospital, or even when they're leaving. A readmission really has to go with what is happening at the time the decision is made for the patients to leave the hospital. So are we doing the right things before they ever walk out the door, right? Are we getting their medications? Do we set up an appointment for them to be seen by, by a physician or a practitioner as soon as they leave? Do we have a system where if they have a small concern, they could reach out to one of our professionals and say, hey, I'm concerned about this. Should I come in for that? So to say, oh, high readmission rate means the hospital is bad. Again, this is one of these areas you talk about. That's kind of the mystery, right? What's causing that? But the drill down, the analysis, the looking for clues comes down to saying, let's look at the types of patients that are being readmitted. Let's see what is the time interval. Because a readmission that happens within the first day or so is generally caused by a different thing than a readmission that's happening a week or 2 weeks out, right? And what's bringing them back in? Is it pain? Is it that, I ran out of my medications? Is it that they really developed a brand new problem on top of the one they had? So it's understanding the same thing. Understand what's driving it. And the last problem with readmissions has to do also with sometimes outside the hospital's control is what does the community around the hospital look like? Do most of the patients you see, do they have primary care physicians? Is there a really robust community health system? So if a patient does have a problem, they can just call somebody up and get seen that same day. That is kind of a system that's really helpful to keeping readmissions lower. But in some settings, you think about sometimes rural hospitals where the patients, when they leave, they go off in many directions into areas without a lot of care. That can be much, much more difficult to manage readmissions because if they have a problem, they don't have any place to go. They got to come back to the hospital. That's the only source of care that they have. So again, it's one of those mysteries you have to unravel. Is a high readmission rate a good thing? No, probably never a good thing. Is it a terrible thing? It's more a matter of saying, let's understand the causes of it. Let's try and prevent readmissions to the greatest extent possible. But at the same time, at the end of the day, there'll always be readmissions because it's some situation you just cannot plan for. There are certain situations where the patients absolutely should come back to the hospital and absolutely should be readmitted. And that we'll probably never be able to control that completely.
So if you've got a problem with readmissions, I guess the first question you're going to ask is, do you have good preoperative process? Do you have good post-operative rehabilitation processes? And do you have good access to local primary care? Because those, we talk about that idea of what is the most common solution to a problem. I guess what I'm hearing here is that if you've got a problem with readmissions, these are the first places to look.
Right, exactly. I think you hit some really key pieces. Talk about the pre-op piece. That's sort of a critical one. For years, for decades, really in the U.S., and it's still a lot of hospitals are this way. Their sort of pre-op process, their pre-op clinic, was really a lot of times just somebody, bringing a patient in, kind of listening to their heart and lungs, and saying, "Yeah, I guess they're okay. Go on in." Right. And that is absolutely not the way to do pre-op evaluations in this day and age. You need to do a much more sophisticated evaluation of the patient, but a great preoperative clinic does a whole lot more, right? They're going to look at patients and they're going to say, okay, besides looking at this patient's risk of, say, having a heart attack after their surgery, I'm going to look at this patient's risk of having a readmission. So in other words, do they have a primary care physician? Do they have lots of medical problems? Do they live alone? That's a great one, right? It's a risk factor. If patients live alone, there's no one that can help them there. Sometimes they get into trouble and their only alternative is to come back in. So a great preoperative system will identify those patients who are at high risk for readmissions. And then even before they come to the hospital, you're going to start saying, okay, what are we going to put in place? Maybe we're going to have a nurse come visit them every day. Maybe we're going to arrange to have them see their primary care physician the day after they go home. Right. So in other words, you say that's what's when they talk about a lot is so many of these problems you can only solve them by working on it upstream. Identify the patients at risk, readmissions or otherwise. Implement we call them the evidence-based best practices, meaning the stuff that research has shown is really the best way to do stuff. Identify those patients who have readmission risk, and then do stuff in advance of them ever leaving the hospital. Again, you may not eliminate the readmissions completely, but a great preoperative process on it will cut readmissions in surgery patients in half, or if not better.
It's interesting because actually I came across this a couple of years ago looking at European health systems in particular, and specifically I was looking at Germany and Austria, where pre-operative and post-operative care are a huge part of the way the system works. So they actually have prehabilitation facilities and rehabilitation. So you spend a minimal amount of time in the acute facility itself.
Right.
But you spend that. I mean, I guess there's two questions. I mean, one is that overkill? Is that a good idea or is that overkill? Are we doing too much? And I guess the second piece relates to the question we were talking about around sepsis earlier on. If you're spending a minimal amount of time possible in the actual acute facility, are you actually potentially there cutting any potential risk of exposure to things like sepsis?
Well, it's interesting. I mean, it's sort of a broad saying. We don't say it that often publicly, but the hospital is one of the most dangerous places in the world, right? Yeah. And frankly, in general, the less time patients can spend in the hospital, the better off they're going to be. Right now, if you're very sick coming in, you've got pneumonia or something else, coming in for a heart bypass surgery, clearly you want to be in the hospital for some period of time. But as you said, Steve, there's a lot of stuff that can happen in hospitals. It's interesting. Some of the worst, germs in the world develop and sort of, live in hospitals because they can't really live on the outside very much. So, like you said, the more we can move patients through the system, through the time in the hospital, and get them out and get them back to a better situation, that's a great thing, right? One is hospitals are such an expensive place to be. So from a cost standpoint, that's better. But also from a patient safety standpoint, when it's appropriate to get the patient out of the hospital as fast as possible, that's a great thing. Now, again, how do you do that? A lot of it has to do with, again, starting before they ever come to the hospital whenever possible, or at the very least, if they come into the emergency room, right away, the very first thing, along with kind of diagnosing them, figure out what's going on, is look and see, okay, what's these patients' risk factors? What's reasonable time for them to be in the hospital? How can I get them out in a reasonable amount of time? And where's the best place for them to go? Is it home? Is it a nursing facility? Is it another hospital? By doing that upstream planning, you impact a lot of those issues, that happen downstream. Again, one of the biggest failings we see in hospitals, though, is they're just not proactive enough. With their surgeries, with the patients coming to the emergency room, people are just not taking the time to look at all those other factors and then make the changes while you have the time, as opposed to trying to figure it out as the patient's walking out the door.
I mean, one of the greatest ideas that I've ever come across when talking about the argument for preventative care and the argument for remote consultation is the argument that says, well, actually, what do you do with somebody when they're sick? Well, we send them to a big building full of sick people. That doesn't seem like the most logical thing to be able to do, does it?
Yeah.
Well, there you go.
Right. Right. It's very true. That's very true. Exactly. And that's why there has been a lot of push lately to say what can we do safely outside the hospital. I mean, for example, like in the U.S., there's a big push now for most joint replacements, hips and knees and shoulders, to try and as many of those as possible outside the regular hospital setting. Do it like in ambulatory surgery centers where the patient just comes in the morning, goes out in the afternoon. And that's happened a lot because we do a much better job of those surgeries. We're very, very good at them. They're very fast. But also, if you're doing it well, you should be able to, figure out those patients that are safe in that environment. So yeah, well, a lot of push to say, don't bring sick people in the hospital if we can avoid it.
The other thing that I wanted to pick up on here, because I mean, a lot of what we talked about here is around infection, is around sepsis and picking up bugs that you really should hope that you're not going to pick up in a safe hospital environment. But I guess the elephant in the room from that point of view, and the reason that you gave, or one of the reasons why sepsis is becoming more prevalent, is the issue of AMR. So antimicrobial resistance, fewer and fewer of our antibiotics, or more and more of our antibiotics, are failing to work.
Yeah.
In your view, how scared should we be of AMR?
Let's see. How doom and gloom shall we be? I guess, put it this way. And maybe when in doubt, I'll punt to experts that I know. So I have friends that are infectious disease doctors, and let's just call them Dr. A and Dr. B. So Dr. A is like, yeah, we're worried about antimicrobial resistance, but we are producing new antibiotics all the time. It's not a very fast pace, but we are doing some of that. And so I don't see a problem right away, maybe 50 or 100 years down the road, but in 50 years, we should have new antibiotics, which I think will be okay. So that's Dr. A, infectious disease specialist. Dr. B, I'm also a friend that thinks this way, which is, oh, no. If you do the math right now, is how quickly resistance is spreading across all these different bacterial entities, and then put that chart against the chart of how fast we're developing new antibiotics. These are two mismatched curves. The antibiotics are not working at this rate, and they're being developed new ones this rate. And if you do that math within about 2 or 3 decades, you've reached a point where a lot of the stuff that's commonly treated now with very simple antibiotics becomes either much more difficult to treat with much more powerful antibiotics, or can't be treated at all. And there's some people talk about what they call the post-antibiotic age, where sort of potentially all the antibiotics lose their potency, lose their effectiveness. I don't think that's on the cusp of that anytime soon. But this is one of the things that as a society we should really be looking at. We should be doing it very scientifically and saying, listen, if we see this mismatch in curves, we as an entity, as a government, US or anywhere else, should be saying, okay, we should really then start pushing to accelerate antibiotic research, developing new antibiotics, but also understanding what it is that drives antibiotic resistance. One thing about just a small side, think about antibiotics. Antibiotics is a very unique class of drugs. Antibiotics is the only drug out there that if you treat a person, right, one person out of a community, you're not just treating that person, you're actually treating the entire community. Because as it turns out, if you use a type of antibiotic and a bacteria in this person's system becomes resistant to it, when they go back to their friends and family and out to dinner, whatever else, they'll tend to spread that bacteria with that resistance out to everybody else. So literally, overuse of antibiotics in a small group of patients leads to broad-based antibiotic resistance in communities. So that's why it's such a touchy area. It isn't about saying, hey, we're just going to only use antibiotics in certain cases. It's about really understanding how that antibiotic resistance spreads among bacteria, things like that.
I mean, I think it's a really interesting one, isn't it? Because I think this is something that became prevalent and became obvious during COVID, was that viruses, germs, they are organisms too, and they have the same desire for survival that we do as human beings. So the more and more you find ways of treating and battling those infections, the more those infections are going to find ways around you. So it becomes this constant game of cat and mouse. I mean, is that the right way to look at it?
Oh, absolutely. When you think about, I guess if you're looking at the bacteria dating pool, right? What makes a bacteria attractive to other bacteria or something? What makes a bacteria strong and successful? Well, it's not how it looks. It's not how it moves. It's not how its little legs stick out and flail around, whatever else. None of those things, right? The only criteria for a great bacteria, a great virus, a great any type of germ like that, antimicrobial, is does it survive, right? And so everything is about, can it spread? Can it replicate? Can it continue to exist? Right? And that's the problem with it, is its entire existence is geared toward that one thing.
Yeah.
right? I mean, think about viruses. Viruses are barely alive anyway, but the thing they do is they multiply, they spread. And so because of that, they are absolutely completely incentivized. If the only thing they need to focus on is how to stay alive, and when you introduce by antibiotics to it, their next job is how do I survive with in the face of that antibiotic. And so they are evolutionarily geared over the last billion years to figure out the best possible way to get around those types of defenses, and they're good at it. And in some ways, they're better at doing that than we are at stopping them at it.
I do remember having this conversation several times during COVID. The whole idea of a virus that it was always going to evolve, and the evolution was always going to be predictable based on its need for survival. So
Right.
Number one, the idea that COVID became less deadly over a period of time as the virus evolved, well, that's obvious and logical, because what organism that wants to survive is going to kill its host as quickly as possible?
Right.
And then the second piece being, okay, it will become less deadly, but it will become far more transmissive, because at the end of the day, what's the other great way of surviving? Infect as many people as you possibly can. And I guess that's the same survival strategy that you're going to see with any organism, virus, germ, whatever it may be.
Right. Well, here, let me ask you a question, and it's actually a trick question. So, if you're not sure the answer, you're correct in your thinking. What is the name of the most successful bacteria in terms of spread through the human race in the last 1,000 years? What's the name of that bacteria that's the most effective in terms of spread?
No idea.
Right. And you know what the name is? It's a trick question because nobody knows the name.
Right.
And the reason we don't know the name is the most effective bacteria in the last 1,000 years has spread among humans ubiquitously, but doesn't make them super sick so that they stay away from other people, doesn't kill them either fast or slow, does not cause major symptoms that make people want to seek treatment for it. So the most successful bacteria out there is probably one we've never actually identified, because it doesn't cause enough damage to the human host to make us either die from it or respond to it in different ways. And that's the problem with it. I mean, like you said, a bad virus, a bad bacteria kills its host and kills its host fast. Sort of a medium skilled one will kill its host potentially as a side effect, but does it much more slowly. A good virus or bacteria will cause sort of the minimum damage possible. The problem is with so many different variations, they're out there growing and killing and doing all those different things, and we sort of get the side effects of their attempt to stay alive.
If Dr. Rick May, healthcare super sleuth, can't find it, then nobody can. Rick, we're about out of time. I want to thank you so much for a really fascinating, really fun debate. I'm sure our listeners will really enjoy this one. Thank you very much, Rick, for joining us. And we'll be back next month, or next week, in fact, with another... I do so many of these days, I don't even know how I'm going to do it. Rick, thank you so much. And thank you also to the dinosaur in the corner of your room. Is there any significance to your dinosaur?
Just because I'm a science nerdy geek kind of guy and I like dinosaurs. So yeah, that's actually a dinosaur I gave to my daughter when she was little and she went to college and she left it with me. So I got the dinosaur back. So that's why I have the
Fantastic. Got custody of the dinosaur. Rick, thank you so much. I'm sure we'll speak again soon. Thank you all for watching. This has been HealthBeats. Make sure you subscribe. Apple Podcasts, Spotify, all the different places you get your podcast for conversations that will probably be almost as interesting as this one. Thank you very much, Rick. Goodbye.
Thank you, Steve. Bye-bye.